Good afternoon and welcome to today's webinar on supporting COVID-19 response and health system resilience as we transition to the next administration. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy, also former commissioner of the Food and Drug Administration, administrator for the Centers for Medicare and Medicaid Services, and an independent board member for Johnson & Johnson and Cigna. With Friday night's emergency use authorization for the first COVID-19 vaccine, and with more vaccines in the pipeline, we're entering a new phase in the pandemic. The vaccination campaign is starting right now with frontline healthcare workers and with nursing homes. But we still are a long way from moving beyond the pandemic. COVID-19 cases, hospitalizations, and deaths have surged to their highest levels. So today, even as we start vaccinating, we'll also pass the milestone of 300,000 deaths related to COVID. And all this is happening as we're in the midst of a presidential transition. President-elect Biden has stated that his top priority is not only ending the COVID public health emergency and assuring an economic recovery, but also doing so in a way that makes the nation more resilient to public health threats and addresses key weaknesses in our healthcare system, like the health inequities that have been so exposed during the pandemic. At today's event, we're going to feature a series of fireside talks, presentations, and panels that address three areas where a smooth transition is needed and where the new administration's policies and actions could have a big impact on COVID-19 response and national resilience. Our first panel will focus on vaccination, assuring that vaccines reach all Americans as quickly as possible and are administered safely, effectively, and equitably to help all communities reopen safely and to help address the very large racial and ethnic inequities that have emerged. Our second panel will focus on COVID testing. With new innovations, more evidence, and more experience, and rapidly increasing capacity of testing, it may be easier to do more routine testing as part of a key role in containing the spread of the virus and allowing schools and businesses to reopen safely in the months to come before vaccination is widespread. And our third panel will focus on steps to support effective healthcare in the pandemic and beyond. That is, steps that help our stretched hospitals manage the current surge through measures like the use of early interventions and alternative sites of care to avoid hospitalizations, and also by strengthening the use of such innovations as virtual care, digital health, and reforms that help address the social factors that have also had a big impact on health outcomes. These are challenges for the new administration, but also for state and local governments and for private sector partners in these efforts. We all have to work together in unprecedented ways in this public health emergency. At the Duke-Margolis Center, we've been working with federal and state governments with a range of these private sector partners to support the national COVID-19 policy response in these and other areas. For example, just in the past week, we issued a comprehensive overview of state vaccination strategies, a set of policy analyses on how to use the newly authorized COVID monoclonal antibody treatments more effectively, and we participated in activities with the Rockefeller Foundation to help states and school districts deploy more proactive COVID testing strategies. You'll hear about some of this work today, and you can find out more on our website if you want to hear about more details. Finally, and importantly, I'd like to thank some of our key supporters for this work: the Gary and Mary West Foundation, the Commonwealth Fund, the COVID Collaborative, and the Rockefeller Foundation. And one more logistical detail: if you have a question or comment during today's sessions, please use the audience Q&A function on Zoom, and we'll try to get to as many of those questions as comments as possible. Well, to start off and to help frame today's event, I'm very pleased to be joined by former FDA Commissioner and good friend Scott Gottlieb, currently a fellow at the American Enterprise Institute and a board member at Pfizer. He's going to start us off with an opening conversation on the current state of the pandemic, including vaccines and therapeutics. And Scott, maybe we could just start there. Again, thanks for joining. In terms of priorities to get to resolution of this COVID public health emergency and a robust recovery, I'm guessing that an effective vaccination strategy is the top of your list. What are your biggest concerns about vaccination in the weeks ahead?
Well, thanks for having me, Mark. You used to introduce me as a former senior advisor to the FDA when I worked for you.
I guess you graduated.
I graduated. Good to be here with you. A lot of the focus has been on the the logistics and the cold chain that needs to be maintained with this vaccine. And I think that that's been largely solved for. And I'm not saying that that's easy or trivial, but there's been a lot of effort put into that. And as you mentioned, I'm on the board of Pfizer. Pfizer developed this special box that can keep the vaccines secure and cold, properly stored for up to 10 days in shipping. And there's flexibility in the system. The system is very good at handling cold chain storage, and so are the major logistics companies that are going to be moving this vaccine. The vaccine, when it arrives, can be put in an ultra cold freezer for up to 6 months. It can be stored in that box for up to 30 days. You have to repack it with dry ice every 5 days once you open that box. But as long as you keep that box shut, it can remain stable for up to 10 days. And the other thing you could do is thaw the vaccine and keep it refrigerated for up to 5 days. And so that's what they're going to be doing actually when they go into the nursing homes, is they'll thaw it in the morning and bring it with them in refrigerated containers to the nursing homes. And you can just keep it in standard refrigeration, -4 degrees Celsius. So I think that the system is going to be able to solve for those logistical issues. What I'm worried about is the distribution, that last mile, the distribution in the community, being able to bring in individuals from the community who are eligible to be vaccinated, go and find them, try to provide for the opportunity to get vaccinated when you're dealing with a vulnerable population. What we're seeing with the antibodies, I think, is a cautionary tale, where there's a lot of heterogeneity across the country in terms of access to those antibody drugs. And there's some states that have made very little distribution of the antibody drugs because they haven't stood up distribution sites yet. I'm worried we're going to see the same thing with the vaccines. Now, it won't be apparent this month because by and large, the vaccines are going to be distributed at nursing homes, and CVS and Walgreens have largely solved for that. And they're going to be distributed to healthcare providers at hospitals. And so hospitals will know how to deliver vaccines to their workforce. But once we start to get into vulnerable populations in January, when we're either vaccinating certain components of essential workers, or more likely vaccinating an elderly population in the community where you're dealing with individuals who might have a hard time coming to a vaccine distribution point, I'm very worried that we haven't worked out all the logistics of that last mile. We've had so much focus on the cold chain and getting it from point A to point B, which I think is the part that the system's really good at solving for. We haven't focused as much on that last mile, getting into the community.
Yeah, really the last mile is a challenge. And our next panel is going to take on that topic. But related to that, you mentioned a number of priority groups. If you add up the essential workers, elderly, people who have serious comorbidities, we're talking about 100 million Americans. And it's going to take some time to get through that group, assuming you can work out good mechanisms to go the last mile and assuming you can address some of the confidence issues that people have had with the vaccines. Any thoughts about prioritization and guidance for the states on that?
Well, look, I believe strongly that we should be prioritizing an elderly population, and I've stated that. I think that governors have discretion and will take discretion to make individual decisions for their states to try to address communities that have been particularly hard hit by the virus, certain lower income communities, certain essential workers. And when I talk to governors, they all are going to be making sort of one-off decisions to allocate certain proportion of their vaccine to certain special needs. But I think vaccinating an elderly population when you're dealing with a scarce resource is going to maximize preservation of life with this tool. And I think that that should be, frankly, our primary goal. How do we maximize the preservation of life with the vaccine? And it's by and large, older individuals, age is the strongest predictor of bad outcomes and of death from COVID. The other thing that we need to keep in mind, and this is another reason why I'm an advocate of trying to target an elderly population initially, is you need a system that can actually be implemented. And if we're going to try to target essential workers first broadly, we're going to be in long debates about who qualifies as an essential worker, how you demonstrate eligibility. You know, if you're a transportation employee and we're going to say transportation employees are essential workers, which they are, what about part-time workers? What about gig economy workers? And so we haven't worked that out. And confirming eligibility is going to be difficult. With respect to the elderly, we know who's over 65. We know how to confirm eligibility based on age, and we know how to reach those individuals because most of them are in Medicare, and we have systems for reaching out and monitoring when we're dealing with that population. And given the challenges that I think are appearing, for example, with the nursing home distribution with a consents warrant in place, it's becoming apparent we haven't worked out all the issues. And so trying to come up with a system that's practical, that can be implemented, that has some simplicity to it, I think is going to be important as well. So that's why all those reasons are why I've been an advocate of trying to target an elderly population first with a scarce resource.
And along with that, still, at least according to recent polls, I haven't seen anything since Friday's announcement. A lot of Americans, especially from communities of color, have significant hesitancy around vaccines. Do you see that getting better now that there's been not only clear but pretty decisive action by FDA and CDC, statements from all the a wide range of medical groups, health professionals, and now healthcare workers starting to get vaccinated?
Well, look, I think it's going to get better, and I think that having a vaccine that shows such good efficacy is going to help drive participation. And I think hopefully, as things go well, and I hope they will go well, as the vaccine rolls out, more people get vaccinated. We have more data to support the safety and benefits of the vaccine. I think that that's going to inspire more people to get vaccinated. But we're going to have to go in and really make a proactive effort to reach certain communities, particularly communities that are disconnected from healthcare, that face obstacles getting access to healthcare, where there's institutionalized racism that create obstacles to getting access to proper care. Black and Latino communities have been hit very hard by COVID. There are structural challenges with getting healthcare into those communities, Indigenous Americans as well. And so I think we're going to have to really put some effort and some resources into trying to go into those communities, provide good information, try to find people who can be spokespeople for the vaccine, maybe, vaccinate some public figures who help inspire trust and confidence in the vaccine. I think we're going to have to do all of that. Those conversations are happening. I know there's some efforts underway around those kinds of activities, but these are the things that we're going to have to get in place. We will need to do it in January. I mean, December is largely baked in terms of how this vaccine is going to be rolling out, but we need to start anticipating those challenges in January and putting in place measures right now to address them.
Yeah. And now let's say things do go reasonably well with the vaccination strategies. You've projected, even so, if I recall right, we're talking, late spring, into the summer before Americans will have widespread access to vaccination, probably some steady improvements in the COVID case burden, I guess, especially if we start with the highest risk patients first, like the elderly, in terms of bringing down some of the hospitalization burden and surges that we're living through right now. But that's still months before we have returned towards something like normalcy, even with all of this remarkable progress on vaccines, and even if this whole vaccination effort goes well. We have a session today focusing on testing, and that's something that's been, had some real challenges, some that you've written about early in the pandemic especially, but even now, still issues with access. The panel is going to talk about some strategies to make more proactive testing widely available in higher risk settings and potentially supporting broader school opening. Can you comment on how much of a difference this makes and how much it might be worth investing in now to help us get through through the coming months?
Yeah, well, just one more comment on the vaccine, picking up on what you said. I think we need to be careful that we don't assume that the vaccine is going to help us achieve herd immunity. I think in order for the vaccine really to achieve something that is true herd immunity, it has to prevent transmission of the virus and has to prevent infection, at least on some level. Now, I happen to believe it will. We'll be able to demonstrate that in time, but that's complete conjecture. And I base that on the fact that when you're seeing a sort of 95% efficacy, you start to assume that some of that efficacy is being driven by people who aren't getting infected in the first place and not just driven entirely by people who aren't becoming symptomatic. But we don't know that. We'll be able to tell that in time, but we don't know that now. So we need to be careful to say that, not to say that the vaccine will create herd immunity. There will be more supply in the spring, as you said. Part of that will depend on hopefully J&J's success. So maybe you can brief us on that at some point today.
So that next event.
But by the end of January, we'll have vaccinated 50 million Americans, and probably 30% of the population, 100 million people will have been infected with COVID. So we're getting to levels of exposure in the population that the rate of transmission will fall. I think with respect to diagnostic tests, you know,
and actually, well, large scale, not just diagnostic testing, but large scale screening tests in asymptomatic populations will actually help answer that question about how much.
And at home testing, I think the question is, should we make a test more ubiquitous and accept that it's going to have a certain degree of false positives and false negatives if you have a sort of a lower cost test that you're providing at sort of the point of home, if you will. And right now, the guidance from FDA is that they want a test to be 90% predictive in order to allow it to be used for at-home use. I think, you know, the regulatory concern always is that you give someone a test and they use it at home and it says they're not positive when in fact they really are. So it's not a really accurate test. That person might have presented to a doctor, might have stayed home, might have gotten a more accurate test. Now, by giving them that negative result, when they might really be positive, they're going to go out and do things that will propagate the infection. So you actually could be doing a harm. I think we need to rethink that in the setting of a pandemic, because even if those cases are going to happen, if you properly educate people, you can keep it to a low number of people who actually, where you're going to be sort of incentivizing the wrong behavior. You're going to be sending someone out into the community who's positive, who otherwise might not have. But all the people that you might catch now, who now can self-isolate and present for proper care, are going to offset the 10% of cases where you might actually create some harm by giving someone a negative result when in fact they're positive. So I think in the setting of an epidemic, when you have widespread transmission, you know, the balance has to favor more testing, at-home tests. And so I think we might have to rethink the regulatory paradigm there, but there are difficult questions, public health questions that need to be worked through.
Yeah, and maybe some steps along the way with using at-home tests as part of school reopening or other higher risk businesses where repeat testing can help perhaps give more confidence there too. I did want to shift gears before we wrap up and talk more directly about healthcare. You and I have written some about the challenges our healthcare system has faced. Hospitals have been slammed, primary care and other medical practices that have had to dial back their activities when their fee-for-service revenue fell, big declines that are persisting in preventive care like mammograms, vaccinations, also problems with access to treatments for serious conditions like heart disease that still haven't recovered, all of which suggests, you know, we're not going to be done even when we're through the public health emergency in terms of the health and mortality consequences for perhaps months or years to come, as well as the disparities. We have seen a number of organizations implement steps like virtual care models, home-based services, steps to use digital health, longitudinal data to address needs during the pandemic, like mental health or social factors, social determinants of care. Do you see any potentially promising steps coming out of this experience to make those kinds of care reforms more a broader part of the U.S. healthcare system and maybe a part of resilience, so we're better prepared for the next pandemic and delivering better care in the meantime?
I think we're going to be facing the consequences of the accrued morbidity as a result of this pandemic for years to come. It's going to take us a very long time to regain some of the improvements in health that we've made and get back to a baseline. You know, I do think that there has been a lot of cultural changes over the course of this pandemic in terms of people's use of technology, and they're being more comfortable using technology to deliver care, not just patients, but especially providers who never were on virtual platforms before, now using it to deliver care and finding it to be very effective and figuring out how to use it effectively. So I think that there's going to be a lot of opportunity to continue to accelerate the adoption curve and use that as a tool to try to get more care more efficiently out to individuals that will help us work off some of this accrued morbidity.
Yeah, hopefully silver lining to some of these challenges ahead. Scott, thank you very much for joining us today. This is a last question. So Congress seems to be perhaps getting it together during this lame duck session on a COVID relief package. Any thoughts or insights about where that's likely to end up this week? It seems like it would be a big help in addressing some of these challenges around vaccination and testing and
Yeah, I mean,
and making a healthcare system more resilient.
it looks like it's going to get over the finish line. I think that the bottom line is you're going to see more governors reach for certain kinds of targeted mitigation, closing hospitality. And we can't ask the hospitality sector, small business owners, restaurants to bear the brunt of the collective action that we need to take to try to slow the spread. Congress has to backstop those businesses. And so hopefully they'll get this done this week.
Thanks, Scott. Always great to see you.
Thanks a lot.
Thank you very much. All right, and I would like to turn now to start right into our first panel on vaccination, moderated by Hamie Tourson, who is a senior visiting policy fellow at the Duke-Margolis Center and recently joined us from the National Governors Association. Hamie?
Wonderful. Thank you, Mark, and great to be here with you today. Well, we are going to spend the next 30 minutes just digging a little bit deeper into vaccine distribution challenges. So, I think Scott's remarks were so well taken. Now we have an authorized vaccine. It's an incredible development, but it's only going to be successful if we can actually get the vaccine into the arms of millions of Americans. And states and localities are responsible for that last mile or inch of vaccine distribution. In trying to address, the last mile or inch, there's going to have to be collaboration with the federal government, providers, health plans, manufacturers, and communities, among others. And that is going to be sort of a critical element to making this be successful. So over the next 30 minutes, we're going to really talk about how state and federal leaders can build more trust in the safety and efficacy of the vaccine. We'll dig a little bit deeper into the distribution and administration challenges that states have experienced, which includes things like addressing some data challenges and thinking about how they're going to actually prioritize amongst populations. And then we're also going to talk about how we can better engage the community, because I think we've seen a number of studies across all the different things we've been looking at that shows this isn't your regular run-of-the-mill vaccine hesitancy. This is a different type of product. And for example, there are some studies that have shown that women are more hesitant, and they're often the healthcare decision makers in their household. So as well as particularly communities of color, which we're going to actually explore as well in this conversation. So I first wanted to introduce our great panel that we have with us. I'm so pleased to have, I'm going alphabetical order. Jim Blumenstock is the Chief Program Officer for the Public Health Practice for the Association of State and Territorial Health Officials, otherwise known as ASTO. His portfolio includes the state public health practice program areas of infectious and emerging diseases, immunization, environmental health, and public health preparedness and security. And I know Jim has been working night and day, 24/7 over the past several months with the state health officials, really, who have been on the front lines of all this. So he's going to have an amazing perspective to share with us today. I also wanted to welcome Dr. Helene Gale, who is the president and CEO of the Chicago Community Trust, one of the nation's oldest and largest community foundations. As an expert on global development, humanitarian, and health issues, she also is president and CEO of CARE, a leading international humanitarian organization, and worked for many years at the Centers for Disease Control and Prevention. So she is also going to bring a wealth of experience to the conversation today. And last and certainly not least is Dr. Grace Lee, who will be joining us in just a few minutes. She is a professor of pediatrics at Stanford University School of Medicine, and she has deep expertise on vaccines. She is serving as a member of the U.S. Advisory Committee on Immunization Practices, otherwise known as ACIP. She's a member of the COVID-19 Vaccines Work Group and chair of the COVID-19 Vaccine Safety Technical Subgroup. And she is just coming right out of those ACIP meetings that have just been happening over this week. And I think she'll have a really good perspective to share on recommendations of how to prioritize the vaccine amongst the public. So before I turn over to the panel to ask a couple of questions, I also just want to talk a little bit about the work here at Duke-Margolis. So as Mark mentioned, we released a paper last week in partnership with the National Governors Association and the COVID Collaborative, where we analyzed all of the state and territorial vaccination plans, really to identify common themes, unique considerations, and challenges across planning domains, and really to identify a few examples of what states are really trying to do to address all of those. And I just wanted to highlight a couple of topics that we are then going to delve into in our conversation with our panelists. Some of the biggest challenges up front that we identified and that I think we all well know is funding for state and local governments. ASTO and the Association of Immunization Managers have identified a need for $8.4 billion. I know Jim is going to talk about this, but really this is an unprecedented effort to vaccinate millions and millions of people across the country. And our systems do not have the capacity that is needed to really get this done. So funding is going to be critical to be successful. Prioritization. Scott talked a little bit about the prioritizing healthcare workers and making sure we get the elderly the vaccine first, because they are the population most at risk. Beyond those populations, I think states have a lot of questions around how do we equitably distribute the vaccine. Governors and their staff, of course, are getting a lot of requests and concerns from different types of populations interested in being prioritized for the vaccine, and making those decisions will not be easy, because it will just be phased over time in terms of which vaccines they'll be able to distribute to which population first. Workforce. So another challenge that we addressed was in our review is we need substantial additional provider capacity to really to support distribution at this scale. And for example, scope of practice laws limit available vaccinator base, and several states are examining these laws to onboard other health professionals such as advanced EMTs, therapists, and dentists. And then I think Scott talked about the storage capacity issue, and that some of the cold storage can be addressed. I think some of the questions that we saw in the state plans and talking with state officials, which I'm sure Jim will expand on, there is going to be some challenges with having multiple vaccines. So, the Pfizer vaccine, which has now been authorized, needs cold storage, but the Moderna vaccine does not. The Pfizer vaccine, you need a follow-up dose after 21 days. The Moderna vaccine is 28 days. And so making sure that there's provider training and actually administering those vaccines, that the public understands the differences, I think it's going to be critically important. We've already heard from states saying that, they are prioritizing the Pfizer vaccine for only certain types of healthcare providers, and they're waiting to get to those rural providers in other areas until they have the Moderna vaccine because of the challenges with the cold storage. So I think coordinating that and making sure as there's a broader number of vaccines available, I think will continue to be something that states will have to focus on. Data. So do want to spend a couple of minutes with the panel talking about data. Even though states have their own immunization systems known as IIS systems, they are going to have to build new processes, requirements, and other systems in order to connect to the federal database, as well as making sure that they're able to have the capacity to enroll providers, making sure they can follow up on doses, and really being able to track all of the data elements that the federal government is requiring them to do. So some states are adding additional functionality, integrating third-party tools, or supplementing with federal technology. But there have been some challenges with connecting with the CDC system, which could, of course, serve as a federal database to make sure we have a nationwide picture of everything that's happening with vaccines across the country. Multiple states have indicated that laws in their state prohibit reporting of identifiable data to CDC, as well as what systems are allowed to report IIS data or dictate certain consent processes for reporting information. So states are continuing to navigate those legal challenges. I think another piece we're going to talk about in this panel is tracking adverse events, making sure we understand the people who get the vaccine, what will happen with their health as following them in their progression after they receive the vaccine, and how the systems are going to support that. So I know we have a couple questions from the audience on that topic, and we'll be sure to address that in this panel. And last but certainly not least, equity and communication. So I think Scott articulated how the pandemic has really magnified existing disparities in health amongst Black, Indigenous, and other people of color. And really, with those factors in mind, there really has to be a focus on equity and how through communication, through engagement with the communities, through true collaboration, this effort can reach those populations that right now are uncertain about the safety and efficacy of a vaccine and really don't want to be first in line to get that. In terms of broader communications, states, as I mentioned earlier, are also thinking about how to roll out the message to the public. And, we have an authorized vaccine, so messaging needs to start happening now. And talking to a number of states, they're certainly starting to put out, public service announcements, frequently asked questions. CDC just announced their toolkit. The Ad Council is trying to build a national campaign to really make sure that there's awareness across the country of what it means to be vaccinated and why that's important, why it's safe. So lots to talk about. I wish we had more time than we do, but for the next 20 minutes, I think we have a lot of things to discuss. So I want to get right to our panel. And if it's all right, I might just go ahead and pose a couple of questions to each of you. And so I see that we have Dr. Lee with us. So I will start with her. So you have been in the midst of, ACIP deliberations and really wanted to get your perspectives on how will states and localities implement those recommendations and what challenges do you foresee?
Thanks so much for that question. As you know, we've only at this point made recommendations formally about phase 1A, which include the healthcare personnel and long-term care facility residents. And I do want to emphasize that the NAM report that Dr. Gale led beautifully was one of the key aspects of that report in particular was its focus on equity, which I think has really carried through in the ACIP deliberations. And I want to emphasize that actually equity occurs at every phase. So people think about healthcare personnel. Some of our highest rates are in our lower wage healthcare personnel and not necessarily always in the docs that are perceived to be on the front line for everything. So making sure that we implement equity at every stage is a challenge that we bring up upon ourselves. I think one of the things that I've realized now, thinking about talking with states and counties and actually also implementation at our local level, is the challenge with the national recommendation that is intended to be very population-based and again, to address equity. But the challenge being that how you do that can differ based on what level you're working at. So at the state and county level, I've really appreciated that the state of California, for example, has created equity as one of its outcomes and metrics that has kept it front and center. And that enables us to focus on the social vulnerability index that was brought up in the NAM report as a key component of thinking about how to allocate at a state level or even at a county level, for example, thinking about safety net hospitals or federally qualified health centers and making sure that you're getting to facilities that serve underserved populations. And then within our facility, of course, we're focused on individual vaccination and making sure we're thinking about equitable distribution amongst our healthcare workforce. So I hope that, and I recognize the challenge of implementation at every phase. And I've also recognized that depending on how it's interpreted at the state and the county and the hospital level, what we intended at a national level to address equity may not always come to fruition unless we are attentive at every level for how we're addressing equity and making sure that we're not inadvertently increasing disparities by focusing on the wrong things.
Yeah, thank you. We are going to follow up on a couple of points there, but I want to make sure I can get to our next question with Jim. So Jim, you are working hand in glove with the state and territorial health officials. So are they ready for all the vaccines they're receiving? What do you think are the most significant challenges and what do we think we should be focusing on in the next month?
Wow, great, Amy. Great questions. Great questions, multiple there. And it also gives me the opportunity to play off your opening remarks and that surfaced during the conversation between Mark and Scott. First, the direct answer is yes, the state and territorial health departments are ready for this historic public health venture. A lot of their experience is grounded on the experience and the practice, historically going back to H1N1, the lessons learned, the improvements that have been put in place over the last 10 years for pandemic preparedness and response. They practice a lot of the skills and have the skill sets basically every day for everyday emergencies, whether it be hepatitis outbreaks, meningitis outbreaks, last year's measles outbreak. While the scale, scope, and speed of the COVID pandemic vaccination campaign is a lot different, again, the same key elements and core principles are there. So this is not new to them, and certainly they are ready. They have developed their plans, which were required to be submitted for federal review by October 16th. They were all reviewed. Constructive feedback was provided for continuous improvement. States have not only took to heart some of the feedback that CDC and Operation Warp Speed provided, but again, it's an iterative process. All those plans that were submitted 2 months ago were draft interim plans, and I could say with a high degree of confidence that basically every day those plans and the policies and procedures and protocols that back them up have been getting better and stronger, going forward. they've also had the opportunity to practice some of the key elements in their plans. You know, in a perfect world, I think most states and territories would have hoped for a little bit more time so they can get more practice and experience in some of the new features of this campaign, but it is what it is. So, you know, they were able to prepare and practice some issues like data exchange for the information technology features that you highlighted in your remarks. 2 or 3 weeks ago, they were able to practice ordering and receiving mock shipments of the Pfizer vaccine. And actually, I just, to that point, I just wanted to share with you, we canvassed our members, the state and territorial health officials, after that simulated functional exercise. And about 50% of the jurisdictions felt that end-to-end simulated exercise revealed that overall it went as planned, and they were pleased with the results. A little under 30% found that there were some minor glitches they experienced, but overall they were satisfied with the results. And about 25% found one or more significant issues that surfaced that warranted attention before the program went live. So, I mean, that's a classic example of, number one, having the opportunity to practice and evaluate their performance, but also have ample time to identify some of those shortcomings or deficiencies so that the necessary improvements could be put in place before game time, so to speak. So that's sort of the state of play, if you will, on the planning activities, and also to acknowledge the fact that readiness and planning is not an endpoint. It is a process. And, you've all heard this before, but it warrants repeating. Tomorrow's activities will be stronger because they're being informed by today's activities. Just like what we experienced, recently with the ACIP and other determinations on some adverse events based on what happened last month and observed in the United Kingdom. So that just, to me, that's just 2 examples of how, as time goes on, we learn more, that whether it be science, evidence, or just, skills and tricks of execution, this campaign will continue to get bigger and stronger as we go forward. As far as some of the challenges, you and Scott, identified a few of them. But there are a couple of areas that I would sort of like, just like to highlight real quickly. There are 4 or 5 areas that the state and territorial health departments have to manage. They have to manage the risks and the threats associated with the campaign and those things that could be disruptive to a successful vaccination effort. And you all know these threats, they exist every day, but these are really, potentially impactful. They would include such things as weather. There's a tremendous logistical aspect associated with this response. In my neck of the woods, we're expecting a nor'easter in the next 48 hours that could have significant effects on air and ground transportation. How is that going to alter delivery and receipt of product? The issue of ensuring that we are as hardened as possible against any cybercrime threats that could interfere with a lot of the material management information sharing. Production shortfalls is another example that we have to realize that we are vulnerable to supply chain vulnerabilities and flexibilities that could also affect the issues. So those are sort of like to me, those are the higher level, broader, longer term aspects that won't go away. And they just need to be continually successfully managed, and interventions need to put in place to minimize or mitigate their impacts. And the last point I'd like to share before I turn it back to you is managing expectations. The worst thing that could happen is overpromising and under-delivering. And there are a lot of factors or dynamics that really could tip that scale. So I think as we start with our planning and our communications and our engagement with the community, we all need to just remain acutely aware that we've got to temper our enthusiasm and remain as accurate and honest and consistent as possible in our work with the community that we're all served to protect.
Great, thank you, Jim. And before I turn over to Dr. Gale, I also just wanted to ask about the funding. So, we're in the midst of, Congress discussing a package as we speak. We have certainly learned that the public health system has been underfunded for many, many years, and the capacity needed to do all of these different pieces certainly seems to be at risk. So do you want to just have a short comment on that?
Absolutely. So, public health funding, the bedrock is a little weak to begin with. So, you know, that, and we just need to acknowledge that this,
Yeah.
you know, there's really nothing, you know, strong that's underpinning this effort because of years or decades of neglect. Just to sort of give you, you know, some points of reference, you know, 11 years ago when we did the H1N1 pandemic, which was a much simpler campaign compared to today, about $1 billion was appropriated to state and territorial health departments to support the last mile types of activities. Even a couple of months ago, Dr. Redfield gave testimony from CDC that in his professional judgment, it would take between $5 and $6 billion. To date, only 200 million has been awarded to states, principally for planning and pre-event readiness. You know, our estimate of 8.4 billion is a comprehensive plan for the duration of the campaign so that we could successfully, safely, and efficiently and equitably administer the vaccine to upwards of 300 million individuals, many of whom will require a second dose, as well as longitudinal contact to address, you know, their concerns, their interests, and potentially adverse health effects. So, you know, the issue is there's been so much sincere and appropriate investment in the upstream components of vaccine research, development, and manufacture. It would only make sense to us that that same level of commitment and vigor is applied to the last mile that's responsible for the safe, effective, and equitable administration.
Can I put a
Thank
finer
you.
point on that? I just want to emphasize.
Go ahead, Grace.
You know, we're getting estimates that the health impact alone, not even the, you know, the true economic impact, but the health impact of COVID-19 in the US population is $8 trillion. We have invested $10 billion in vaccine development and a few hundred million in the vaccine infrastructure. And I just have to say that, you know, number one, it is incredibly important, and I'm very grateful that so much has been invested in the development, because we're here today and we're able to actually start to vaccinate this week because of that. But the success of the vaccination program depends on sufficient infrastructure to be able to fund it. And really, we can develop great vaccines, but if we can't get it into the arms of individuals and used by individuals, then we're not going to be as successful as we want to be. So investing in the delivery infrastructure is huge. The other thing I'll just say is that, you know, even I know that some colleagues, of course, you know, there have been robust vaccination programs that have been going on for decades, and have full faith in my colleagues in the healthcare delivery system and the public health system that have been doing this for a long time. But the thing that's the hardest is really to reach communities that are hard to reach. And that's, I think, where the investment needs to go towards. We're not going to be able to do it equitably or efficiently unless we have that investment.
Well said. Thank you.
Thank you. Thank you. And Dr. Gale, that's a perfect transition to you to talk a little bit more about, you know, how can we really do what we need to do to reach the populations that are in need. Oh, and I think you're on mute.
Thanks. And I would just, there's lots of dittos that I could say. You know, first of all, just to go back, you know, Grace mentioned, and probably you didn't highlight it, but, you know, what this summer I was involved, I co-chaired the study that CDC and NIH commissioned the National Academies of Medicine and Science and Engineering to develop this equitable framework that I'm glad to hear, Grace, that was very helpful for ACIP. You know, as everybody knows, ACIP does the very specific recommendation to CDC, but I think this study came at a time when, you know, there were lots of unknowns, but it was very clear that it was important to have a framework that put equity at the center of it from the very beginning, and to wrestle with some of the very tough issues that now may seem almost obvious, but at the time when we were going into it, it wasn't. You know, as an example, Scott's mention of the elderly, you know, when you're in public health, you know, we often talk about DALYs and, you know, disability adjusted life years, which would skew you more towards the younger population and not the elderly. We felt very strongly that because equal concern or every life having equal value was such an important part of this, that in fact the elderly that had borne the brunt of this, you know, needed to be prioritized. So just to say, I think, you know, those guidelines and that framework, and the fact that we were asked from the very beginning to put together a framework that was based in equity, really guided how we thought about those guidelines. And the risk framework that we used, which looked at, risk of infection, risk of severe disease and death, risk of negative consequences to society, again, we're geared towards the very things that put populations at greatest risk. So I think, all throughout the framework, and you mentioned the use of the social vulnerability index to be able to make sure that populations that were highest on social vulnerability, people lower socioeconomic income status, minority status, people who lived in multi-generational or crowded households, et cetera, that those geographic populations got prioritized. So just to, I think that the very framework that was developed at ACIP then took and really focused it once we knew the vaccines that were most likely to be available, I think built that into it. So to that point, as everybody has said, now the point is, how do we actually make sure that it gets to the people? Because the last thing we would want is to have put all this effort into developing a vaccine where equity is such an issue and then it not get to the populations at greatest risk and who have borne the greatest brunt of this. And so, I think again, when I look back to the recommendations that we made, 3 of the recommendations were focused on the issue of the reluctance of populations to take the vaccine, and particularly looking at this issue of communities of color. And we know, 58% of African Americans say they will not take the vaccine. And in our recommendations, we felt very strongly that there needed to be both communication at the national level, so that there was a national campaign, everybody getting the same information, transparency, how was this vaccine developed, what are the risks, so that there is a clear communication at a national level. But then it had to be localized. And it had to be localized using organizations, messengers, methodologies that will reach the populations that are hardest to reach. And unless we really put the resources into that, and I would, again, ditto, it would be a shame if we put billions of dollars into a vaccine and then didn't put equal amount into making sure that people got vaccinated. So, that's where a lot of resources need to go. We're thinking a lot right now about upfront healthcare workers, nursing homes, et cetera. But it's really that longer tail, when we get to March, we get to April, when we're getting to the general population, where we have to have the resources to get into those communities and do it in a way that is relevant. The other cost issue is that there should, which was another recommendation we made, that there should be no out-of-pocket cost for anyone. And that includes the administration cost, not just the cost for the vaccine. Because again, it would be a shame if we developed this vaccine, and then cost was a barrier when we put equity at the center. So all of that to say, yes, we know we have a lot to build on. I spent decades of my life working on HIV, where we developed all sorts of community-based efforts. Those things still exist. We know how to reach communities, but we've got to do it in a thoughtful way, and we've got to do it and make sure that it's well-resourced.
Yeah, and Hammy, if I could just add one point too, is, all of this on top of the fact that the healthcare workforce and the public health workforce are still working very hard to address the illness and challenges around containment and mitigation of sickness throughout the country, as well as the other public health and medical emergencies and crises that they deal with routinely. So this is not an either or. This is basically a collection of everyday and unprecedented public health and clinical emergencies that our respective sectors are managing, and therefore the resource needs.
Yeah, no, thank you. And that was great commentary from both of you. And I know we have to wrap up in a couple minutes, but one thing I just wanted to observe. So, I've worked with governors and their teams for a long time when I was at the National Governors Association, and states are where my heart is, but there is variation across how states respond. And that's been true throughout this pandemic. And so one of the comments I just wanted to make was that, just even looking at the plans with respect to equity, there are some states that are really putting it front and center and focusing on it, and some states that are not. And the ones that are putting it front and center have, to follow up on your points, Dr. Gale, they have decided they're going to make community-based grants. So, there's going to be things that happen at the state level, but there's also going to be some direct investment in the community. I think some of the things that you're highlighting is why that needs to happen. And so I just say that because I really hope states can learn from one another, as I know they always do throughout this process, because it's not going to be perfect. And I think we're going to see, especially with respect to reaching communities of color, there's going to be variation in how well that's going to be accomplished, especially in the early days. And my feeling is unless they start communicating now and really reporting on how things are going, it's hard to bring a population along later. So investment in these resources needed. And if I could just follow up on one last question, then I promise we'll have to move to the next panel. We've had a couple of questions from the audience about how can we effectively track and respond to adverse events in vaccines. That is not a simple process, especially when we're talking about the millions of people who are getting vaccinated. And Grace, I might look to you first to perhaps talk about that.
Sure. So I will say there's, so first of all, there is a ACIP group that is specifically tasked with looking at vaccine safety post-approval. And we are planning to look at all of the information coming in real time from a variety of federal safety surveillance systems. Some of these safety surveillance systems are longstanding and have been doing real-time surveillance for decades. Others are newer or more novel surveillance systems that have been stood up in response to the COVID-19 pandemic. Would anticipate that we would have all of this information forthcoming, not only to be able to share about information. I think the biggest question I get often is, is a vaccine safe, or is the vaccine safe in people like me? And so I think we're going to have to be able to address that question post-approval, because if we can't address that question well and speak to it transparently with what we know and what we don't know, we were not going to be able to boost vaccine confidence. And so I can reassure you that there are multiple eyes on this, that there is coordination at the federal level to be able to accomplish this goal and to monitor in real time. And I anticipate that via ACIP, because we appreciate being able to use a federal advisory committee and an open and public process to be able to make sure that we are providing timely and transparent information to the public on this. I'm happy to delve into specific systems, but maybe at a different time.
Yeah. And Hammy, if I could just add, I mean, there's a brand new tool that's been put in place too called VSafe, which is a smartphone-based program that provides both text messaging and web surveys. So this is an opportunity where everyone who receives a vaccine will be informed and encouraged to register and participate. So this gives them, relative real-time connectivity, with experts, either through texting, surveying, or if there are adverse events, to actually have a one-on-one consultation. So in addition to VAERS and other mechanisms, this new feature will make it much more personal and much more interactive between individuals receiving the vaccine and CDC and Operation Warp Speed. And the state health department's role here is to really encourage and educate recipients of the vaccine to really seriously consider taking this opportunity. It also provides recall notices for the second dose and has other features as well.
Yeah, and I was just going to say, I think that this issue of data is going to be incredibly important, because it's going to be the way that we'll be able to be as transparent as possible. And I think the more that we're able to focus on having good data systems, this is not going to roll out 100% without hiccups. And we've got to be honest, we've got to be straightforward about it. And having the data is going to help us to be as transparent as possible and continue to build that trust that is so badly needed if we're going to be successful in this effort.
Yeah. Great last words. I just wanted to thank this panel. It has been a really great discussion. I wish we had more time to talk about all of these things in more detail. But with that, I'm going to turn it back over. Thank you again for joining us on vaccines. And we're going to turn over to the testing panel now.
Thank you so much, Hammy. My name is Marta Woszinska, and I'm the Deputy Director for Policy and Consulting Professor at the Duke Margolis Center. As Hammy said, we're going to now turn to testing. We spent basically the whole hour talking about vaccines, something that we have been planning for for a long time, and you still see how many challenges there are coming forward. With testing, we didn't have much time to plan and have been playing catch up since. So what we plan to do in this session is to talk about where we are now and how to think about reducing COVID-19 cases through efficient diagnostic testing, how to identify and prioritize routine screening testing for high-risk group settings and populations, and back to the issue of data, how to solve key data and information challenges that accompany these efforts. And frankly, all of this within the context of the vaccine rolling out. So what we're going to do is a little bit different than the previous panel. We are going to start with a presentation from Christina Silcox, who is a managing associate at Duke Margolis, before turning to the panel discussion, and I will introduce the panelists after the video. So if I could now turn to Christina Silcox.
Hi, my name is Christina Silcox. I'm with the Duke Margolis Center, and I'm going to be kicking off the test session by talking about how we can maximize testing's impact. So let's start with this figure from the COVID tracking project showing the average daily new cases per million people in each state for the last 2 weeks. And here what we can see is that the country is not doing well. The vast majority of states are dark red, with a couple who are even darker than that. So what does this tell us? We need to rethink what we're doing. And while vaccines will help, eventually they are going to take time to roll out, as was discussed earlier. So in the meantime, how can testing help? And what I want to propose here is that we need to think about testing as 2 different types of testing. One of which is reacting quickly when we suspect someone has COVID-19. So someone who has symptoms or someone who's confirmed close contact with someone with symptoms. And for that type of testing, you want to make sure it's free and frictionless so that people can get tested as quickly as possible and ensure that there are fast, reliable results to encourage faster isolation, as well as both formal and informal contact tracing. And since the beginning of the pandemic, we really have improved in this space. The amount of capacity for diagnostic testing has greatly increased since the spring. Most people can get results back in a couple of days. However, we do know that there continue to be problems in this space, which especially with communities who lack trust in testing, and also communities that find the testing less accessible. And so what we need to do is make sure that we're using data to understand which communities aren't getting tested at the rates they should be, and really reach out and try to understand what are the reasons for that, and try and help them be able to get that accessible testing that they need. The other type of testing, which we have not been able to do quite as easily so far, is proactively searching out infections. And this is important because we believe that 40 to 60% of people are actually spreading the infection while they are asymptomatic, either because they're never going to show symptoms during the course of their disease or because they haven't started showing symptoms yet. And to catch those infections, what we need are feasible, rapidly deployable, scalable solutions that are really able to proactively search for that silent spread and augment the overwhelmed contact tracing that we know is happening to prevent and contain outbreaks. So to be able to do this sort of routine testing easily, we need to make sure that we are identifying what settings and populations that need to happen in. And here we really want to use a 3-fold risk assessment. 1, what is the risk of an infection walking into a particular setting? This is mostly going to be due with community prevalence, but there might also be other risk factors. Then we want to look at the risk of transmission within that setting. So here we're mostly going to be worried about indoor settings where large numbers of people congregate, but are, for whatever reason, are of public interest to remain open. And we're particularly going to be interested in settings where they're unable to fully implement recommended mitigation steps around ventilation, masking, and distancing. And the third factor we want to think about during our risk assessment is what are the consequences for infection for the population within that setting or a population more generally. And so here, there's 2 factors you want to think about. 1 are populations that are more likely to have serious complications by either becoming more severely ill or more likely to die, but also populations which involve highly skilled personnel who do essential work, where if for some reason large numbers of them are taken out of the workforce, that would really affect the functioning of our nation. So examples of priority settings and groups using this risk assessment tool are nursing homes, schools, first responders, healthcare professionals, prisons, shelters, group homes, and non-elderly congregate care facilities, as well as food processing and other manufacturing. And what we see here is that is a lot of people. And that's really why this routine screening has not happened so far. We just simply have not had the number of tests required to do routine screening for this number of people. However, this is changing. And I do want to give credit for this slide to one of our panelists who is going to be coming up next, Mara Aspinall. And what we see here is that in the next couple of months, we really do expect the testing capacity in the country to really explode, where companies who have existing emergency use authorizations on their point of care tests, we do expect capacity to increase, but we also anticipate there's going to be quite a few new EUAs authorized, both around pooling, PCR pooling, which is great for screening and surveillance, and also point of care and even home tests, which will be very helpful for this type of routine screening as well. However, as I mentioned earlier, vaccines are coming. So what is that going to mean for testing? And so if we go back to our risk assessment, what we see is from the evidence we have about vaccines right now, it really only helps with one of the three risk factors. So we know that people who get vaccinated, the severity of illness and the likelihood of death are greatly reduced. So here you can see that circle is grayed out. However, we really don't know yet how the vaccine affects the chance of infection or the risk of transmission. And so we are going to need studies on those topics to really understand how we might be able to shift testing priorities as certain groups get vaccinated. I do want to quickly end on this slide just to remind everyone that testing by itself is not the solution. It does need to be combined with all the other mitigation steps, because that's because if you use a Swiss cheese model, all layers are important because each layer is not perfect. And that will also be true with vaccination once we put the vaccination cheese slice into this equation. So with that, I'm going to turn this over to our panelists. So thank you so much.
Well, thank you so much, Christina, for setting the stage for our discussion. So let me now introduce our panelists. We have Mara Aspinall, who is professor of practice at the College of Health Solutions at Arizona State University. She's also the managing director and co-founder of Bluestone Venture Partners and managing director of the Health Catalysts Group, and she will provide the diagnostics innovation perspective. We also have Juliana Terhayden, who is a strategic advisor at Testing for America, which is a nonprofit group focused on accelerating COVID testing in universities and schools. She is a managing partner at Third Avenue Ventures and will provide the on-the-ground testing perspective. What are the key considerations for deploying testing? And last but not least, we have Alexis Madrigal, who is a staff writer at The Atlantic and the co-founder of the COVID Tracking Project, which we all know is the go-to place for a lot of data on testing and beyond. He will provide the data perspective. How have we been using data on testing? What have been the challenges? And what does the future hold? So thank you so much for joining us. Let me perhaps begin with Alexis. So Christina showed us a figure indicating approximately 200 million tests that were available in November. Can you help us interpret this number?
Yeah. Well, that number is capacity, not the actual, tests that have been deployed out in the world. By the best count we can make, we're looking at maybe 200 to 220 million tests that have been done in the United States, maybe some more negative tests that weren't actually counted. Most of those tests that we are able to capture in the numbers are PCR tests. Antigen tests, we actually only have reports of a few million. So we know that there are tens of millions of antigen tests that are out there. We know that there are millions at least that have actually been deployed, but we're not really seeing them show up in the numbers. Despite that, testing's at the highest level that it has ever been. We are edging up towards 2 million tests done per day, but they're mostly of that diagnostic variety, the sort of rapid response, not the proactive screening. It's people who feel like they're getting sick, maybe a few people who are getting tested before they travel, things like that. But primarily we're talking about people who are not feeling great or need to be tested for some reason. It's the data pipelines are very messy for this, and I'm sure we'll talk about this more later in the panel. But the main problem is that a test is done at some location, Some of those locations have pre-existing electronic links with health departments and eventually into the federal government, and that data flows pretty well. Other places don't have those things and have had to jerry-rig solutions to report a volume of tests that they never had before in their lives. Some groups feel like we shouldn't even be reporting negative tests because of the burden that it places on local health departments. On the other hand, if you don't report negative tests, you don't actually know anything about testing availability, which has been such a crucial shaper of our knowledge about the pandemic here in the United States. So I guess the forecast here is just as we're sort of getting a handle on PCR testing, we're about to see an explosion of other types of tests, antigen, as well as like different pooling strategies, which we won't have access to sort of what pooling strategy was used, which means, testing several swabs at the same time. Sometimes grouped, say, by classroom, sometimes just pooled together at the lab level, so-called front end or back end pooling. And it makes for a very, very messy data set, as we have encountered for the entire time that we've been working on COVID tracking project. And I expect it will continue to get messier, unfortunately.
Thanks so much, Alexis. We'll talk about sort of what the future holds, both in terms of data and just sort of where we're heading to in terms of testing. But looking back a little bit about some of the lessons learned, perhaps, Juliana, I could turn to you. So Alexis mentioned screening tests. Again, diagnostic tests are much better captured in the data simply because PCR is largely used for diagnostic testing. So with 200 million tests and so many more coming, we will be able to expand routine screening. So what are some of the lessons learned in standing up routine screening programs? What information is most important to communicate to ensure the success of these testing programs?
Yeah, at Testing for America, we helped with the pilot at Delaware State University, where they tested all students and faculty on campus twice a week for the entire fall semester. And the majority of those cases, the positive cases, were asymptomatic. So we agree it's critical to expand testing for asymptomatics with proven tests. DSU and other schools are proof that it is hard work, but it is possible for schools to do this. I think three things are particularly important to communicate. One is that you need leadership from the top. People at an institution need to hear from leadership that testing is important and why, that we're going to allocate time and money and other resources to this. A second key component is to draw on a combination of skill sets and resources. So Delaware State and other schools have a cross-functional team working on this. They draw on outside advisors and resources. Delaware State uses students in their nursing programs as volunteers at the test sites. So it really takes a village. And the third component we'd highlight is that it's not just the test itself, but a meaningful testing program needs to include a complete plan for what happens after the test. Institutions need to report results, as Alexis just talked about, but they also need to provide resources to people who test positive so that they and their close contacts can quarantine.
Thanks a lot, Juliana. So actually, let's now look forward a little bit. So Mara, that great figure that Christina showed in her presentation that looks at the projection and frankly, an explosion of the tests that might be available. I mean, you're projecting that the total number of different types of tests will rise from 200 million in December to 400 million in February, more than 800 million in April, and then even more than that by the time we reach June. So what is behind this rapid increase?
Sure, and it is wonderful to see, but I have to use the word that says finally we're seeing that increase in testing, because I think all of us would have much preferred this increase coming earlier. I see that there are three main reasons for this increase in testing. Number one, as Christina mentioned, new EUAs. Additional companies and additional tests being authorized. Many of these are the largest players in the diagnostics industry, and outside of the US already have proven that they can manufacture the test at 20, 30, and 40 million tests a month. So it's not just aspirational, but these are companies that have a proven manufacturing track record. So that's the first piece. The second piece related to that, but I'm going to emphasize it a bit, which is what I call new modalities. We will see a slew, I believe at least 3, but probably 5 companies, again, the largest companies getting into the central antigen test area. One already has received emergency use notification, not an EUN, not an EUA. So they're starting to market it under a limited way. And these are antigen tests, but instead of doing them in a point of care, you're doing them in a central lab setting. This allows you to do 500 an hour, not just 25 an hour, even in an efficient point of care system. That is a very big deal. The total time through the whole process is an hour, but you've got to get it to the central lab. So for all intents and purposes, it should be much less than 24 hours. The second new modality that Christina mentioned are home tests, but I will say I call these DIY tests because I believe once they become broadly available, I can see a university or a business handing out the test to everyone who arrives at 8:45 and then 9 and then 9:15 or an hour earlier. And that it won't just be used at home, but might be used in supervised setting. I hope personally that there is an approval for that, an authorization for that, even without a doctor's prescription. So that's the second area of new modalities. And then the third one is PCR pooling. What we have found is PCR is the so-called gold standard. It's not perfect, no test is, but that the only way to rapidly expand that to the capacity we have is not doing one test at a time, but in reasonably low prevalence areas, doing 5 or 10 or even ultimately 20 tests at a time. And if the whole test is negative, then everyone in that 10 or 20 is negative. If it's positive, then you retest just that pool. And that allows us to get faster turnaround time. And importantly, which we haven't talked a lot about, is the supply chain blockage. That allows us to use only a little bit more supplies to test 20 than we would to test 1. So those are the key 3 reasons.
So thank you, Mara. So this is really exciting, but just as you said, it's, you know, we wish we had it months ago. And we just now just are starting to roll out a vaccine, right? And there was discussion about how many people might be vaccinated. We're hoping for 50 million in February. Maybe we've seen even the head of Operation Warp Speed mention potentially 100 million Americans being vaccinated by March. So the question is, do we need, so Juliana, perhaps you could speak to this a little bit more. Christina did indicate that we will still want to do testing. Juliana, can you add a little bit more to us? I mean, do we need so much testing?
Look, the vaccine news is wonderful. I think even in the best case scenario, there are still many months to go before we have widespread adoption for all of the reasons the previous speakers mentioned. And it's also not yet been approved for young children. And we cannot wait to open schools. All of our kids need to be back in person as soon as possible. And I think testing is one of the tools that's available now to help our kids and our teachers feel and be safer. And so, yes, I think testing will be necessary for a while. Eventually, we will get to a point where we do not need so much COVID-19 testing. That will be fabulous, but we're not quite there yet. And I'd also like to add that expanding the testing and public health infrastructure is not just good for the current situation, but also for the long term. You know, I hope not, but if there were to be a SARS-CoV-3, 4, and 5, having that infrastructure in place will help us longer term as well.
Great, thank you so much, Juliana. So Alexis, let me turn back to you. You did mention that antigen tests are not really being consistently reported, but the growth that Mara is projecting primarily comes from antigen tests, and some are at home. So what does this mean for data reporting? I mean, you indicated briefly that this is going to be a challenge, and do we expect to be able to collect such data? What does this mean? I mean, states have been using data on, let's say, positivity rate, right? Which is based on the share of positive tests divided by total tests to make some critical decisions. And now what's going to happen next?
Yeah, I expect we're going to more or less lose clean data on antigen tests performed. In many places, you're supposed to get a confirmatory PCR test. And one of the things we've been focused on is trying to keep one clean data stream. So like, can we just keep PCR testing clean? We may lose eyes on antigen testing, but let's keep this signal the way that it was since the beginning. And the real problem there is it appears that when some antigen tests are reported, they actually drop the test type way back up the pipeline. So even data that appears like it might be a PCR test in some state data may actually be antigen tests coming in. Obviously, antigen tests have very different characteristics than PCR tests. So it's not ideal. And we've gone to states like pleading for them to try to try and keep the data clean. And the problem is that it's just happening outside of really their sphere of control. There are some possible solutions, particularly for the sort of point of care testing. US Digital Service has built a tool that allows for the easier reporting of antigen tests. So I have some hope that in places that are very well organized, this may work pretty well, and we'll be able to have at least some jurisdictions where we have antigen testing that's relatively complete. But I would imagine that's going to be quite heterogeneous across the United States.
Well, thank you, Alexis, for that question. Just a quick, actually, follow up to this question, maybe for Mara. You know, Alexis mentioned that it sort of starts early on in the pipeline with some of the data issues. Are there companies, from what you've been hearing, thinking about making reporting for point of care and at-home testing results easier? Is that something that companies are thinking about proactively?
They are, and part of the FDA requirements, or at least guidelines for a home or DIY test, is that you have a reporting mechanism. The challenge has been implementing that and balancing the need for privacy, the need for doing it quickly, and quite frankly, compliance. So many of the tests will have a barcode that people with a smartphone have the ability to scan and then record that they're doing the test and potentially the results. But as we talked about in the last panel, we want to make sure that this testing is available to everyone. Not everyone has a phone. Not everybody is comfortable with their phone recording their test. There are a number of other issues around that. So the answer for the home and DIY test is it's being implemented, but I still suspect that we will not capture 100%. On the point of care test, the manufacturers are adding modules and systems that would talk to their basic unit and collect the information and then send it to public health authorities and then COVID tracking. But that, for the most part, requires extra cost and extra complexity. So it's not been broadly implemented as far as I can see.
Thank you, Mara. So taking it to specifically the K-12 screening and the school context, which is going to be so critical for us to really reopen schools. Juliana, what have you been, in the work that you have been doing with universities, have you been able to report tests in a efficient way, a reliable way? Are there any lessons learned from that?
So the pilot testing for America did at Delaware State saw results in 36 to 48 hours on average for the PCR NGS tests that they used. The testing vendor built a data feed to report results to the state, and another data vendor helped the university build a dashboard for tracking and reporting results. But I completely agree, data management was one of the hardest parts and is a big challenge for all institutions in the K-12 setting. For children, obviously, data privacy and consent issues are even more complex. But as Mara mentioned, in all settings, the reporting and mechanisms and the interfaces are different for different vendors. So it is a hard issue and a challenge, but it's solvable if we're motivated. And the good news is people are working on this as we speak.
Can I have one little thing just to the end of that, which is just that if there's something I wish we were doing more of now, it would be proactively developing the strategies for how to actually test, these public schools. And, we've heard from Juliana before, like the operations, and also just like, well, should you test weekly? What kind of test should you be using? Like just all the things that are actually involved in implementation. It's just been something that has been lacking. I mean, we've seen it at our own school, and I know that there's it's a very broad problem.
Alexis, I should be turning you to some of the work that we have done with the Rockefeller Foundation on K-12 testing protocols. So let me actually now ask the same question of all of you. We have a couple of minutes left in this panel. So if there's one thing that you in your sphere would like to flag to the incoming administration, what would that be? Mara, maybe we'll start with you. What would you like to put on the radar screen for the incoming administration?
Well, one of them we just talked about, the importance of schools, not just for the kids and bridging the education gap that we're seeing exacerbated with the lack of school, but quite frankly, even if it's just economic, if kids fall behind, they will graduate high school less frequently and they will be more and more costs in the future. Secondly, make it clear, get EUAs through the system. There's a significant backlog now. If there are issues, get back to manufacturers, and that may mean that the incoming administration must increase staffing at the FDA or find a way to do that. And then secondly, education. I believe that the American public is ready for home or DIY tests, but we need the broad education program for people to understand how to use them, what they say and what they don't say.
Thanks, Mara. Alexis, what is on your wish list?
Yeah, I really want the federal government to provide even more funding to state and local authorities to build these data pipelines for public health data. I mean, they need so much help. And the way we'd know we had reached success if there was no fax machine involved at any point in reporting information that is crucial to fighting a pandemic.
And presumably also more generally data standards, right?
Data standards would be amazing. Yes. Yeah. Yeah, exactly.
All right, Juliana, what is top on your list?
Yes, no fax machines, please. I would say guidance, to Alexis's point and Mara's earlier. There are a lot of people on the ground at schools that want to do testing, but they're generally not public health experts, and they want guidance both at the high level of how frequently do they test students and staff and with which tests. And they also need guidance on the specifics of implementation. What kind of PPE do workers have to wear? Where do I put the cones? You know, these kind of really detailed questions. And some of these answers exist in different places. People have done it, but having it all pulled together and having an authoritative resource would be terrific.
Well, this is excellent. Thank you so much, Mara, Juliana, and Alexis, for your comments, for the information that you have shared with us. So again, even though vaccines are coming, we really do need testing, and we're very excited that finally we're going to turn the corner with testing. And so to a better not only just actually to get us through this winter, but really beyond. We do want to reopen schools, and that's going to be a key part of school reopening, not just the vaccines. All right, excellent. Well, thank you so much. And I will turn it to Rob Sanders.
Thanks, Marta. I'm Rob Saunders. I direct our research here at the Margolis Center on payment and delivery system reform, and I'm excited to moderate this upcoming panel, which builds on the prior two that really focused on testing vaccines, but thinking about, well, how does the care delivery system need to respond and be able to pivot, which is incredibly crucial to make all of this work. All over the country, we've seen providers and hospitals who have reoriented their workforces. They've transitioned their care from almost entirely in person to substantial amounts delivered virtually, and developed a number of new care models for COVID-related care, as well as for other types of chronic conditions that may be difficult to deliver during the COVID times. However, what we're seeing right now, especially with the most recent surge, is that hospitals and other facilities are feeling substantial stresses with very limited capacity right now. So as we enter the long winter, our task is twofold. How do we make sure that providers have the tools and the resources they need to respond to COVID now? And how can we learn from this experience to make sure that we're building back a better healthcare system that's resilient to those tasks in the future? So we're going to kick off this panel with my colleague Rachel Royland, who's going to identify how payment models may be able to help resilience. And then we'll follow up with a panel discussion to really delve into those issues. So Rachel, take it away.
Good afternoon, everyone. My name is Rachel Royland, and I'm a research associate with the Payment and Delivery System Reform team at the Center. And my task is to set the stage for our last group of panelists, who will be talking about actions that can be taken to ensure greater resilience in our delivery system. A key factor when talking about resilience in our delivery system is the payment system upon which that delivery system is built. As many in the audience may know, COVID-19 has affected providers under different payment systems differently. For those providers under fee-for-service, many have seen reductions in utilization and revenue since the start of the pandemic. And these revenue declines have made it not only difficult to respond to the pandemic, but also threaten the ability of many providers to stay in practice at all, particularly smaller, rural, and primary care providers. Those under value-based payment arrangements have had a bit of a different experience. Depending where along the value continuum a specific arrangement may fall, a provider's payment model can provide some degree of protection against the financial impacts of the pandemic. Those that have participated in arrangements with shared savings have had a bit of a cushion that they could rely on or dip into if needed in order to offset the revenue reductions they've experienced. Others under prospective payments have had more stable and reliable revenue streams since that revenue hasn't been tied to the delivery of individual services. And not only is participation in VBP protecting some providers against the financial impact of COVID-19, it's also allowing them to be proactive in their response to new and ongoing patient needs during this time. As we detailed in a brief the center published this summer, many providers were able to use shared savings or that predictable revenue from under a prospective model to secure necessary personal protective equipment so they could continue delivering care safely to patients. Others were able to leverage the data and care coordination infrastructures that they had developed pre-pandemic to proactively identify and reach out to high-risk patients. And many others had existing telehealth platforms already in place that they are then able to quickly leverage in order to continue delivering care to patients. And so through this experience of COVID-19, we've seen the resilience of a value-based payment system over a fee-for-service one. And moving forward, it would be important to consider how we can further embed value-based payment into our healthcare system and leverage that payment approach to support other redesigns we think are necessary to ensuring greater resilience in our delivery system. And just to help get the conversation started, some examples of immediate actions that could be taken to embed resilience into the system are those that could be taken by Congress. We know Congress is considering short-term financial relief for providers, and that relief would go a long way to helping providers continue to respond to COVID-19. And those funds should be prioritized for helping providers caring for underserved communities, particularly the Latinx and African American communities that have been disproportionately affected by COVID. In addition, Congress could structure a portion of those relief funds to enable providers to transition into VBP. A proposal we released this summer is an example of such an approach that would not only help providers in transition in responding to the pandemic, but would also help them start shifting away from fee-for-service, a system that's not served them well during the pandemic. And in addition to relief funds, Congress has been asked and could consider supporting long-term payment changes, such as those related to the regulatory flexibilities that have been granted during the pandemic. An example in this area is related to the telehealth innovations we've seen take place during the pandemic. Congress could consider granting CMS the authority to expand coverage for those telehealth services, such as remote monitoring, if it finds those services to be effective in reducing costs and or improving outcomes. And such immediate actions could help set the stage for long-term actions, such as those that payers and providers could take to ensure resilience by supporting specific care redesigns, reducing disparities, and rebuilding primary care. Payers, both public and private, could supply resources that would enable providers to move away from fee-for-service and towards value-based payment. Examples of such approaches include CMMI's ACO investment model and Blue Cross Blue Shield of North Carolina's Accelerate to Value program. These are examples of approaches where providers are given upfront supports that allow them to start building the capabilities needed to transition into and succeed under value-based payment models. Payers could also support the implementation of more advanced primary care teams that have enhanced capabilities around virtual care, as well as tools needed to care for diverse populations, such as multilingual and multicultural teams. In addition, implementation of enhanced home and virtual care models for specialized conditions, such as dialysis for end-stage renal disease, could help ensure high-risk patients can receive care safely at home. And finally, payers could increase the accountability around identifying and addressing health disparities through actions such as requiring the reporting of quality measures by race, ethnicity, and other important characteristics, and make sure those providers are held accountable for reducing those disparities over time. And for providers, actions around eliminating low value care could help drive down costs associated with low value services and help ensure that the care that is delivered is more likely to have a positive impact on patient outcomes. These are just a few examples of both immediate and long-term actions that could be taken to ensure greater resilience in our delivery system. And I'll turn it over to Rob Saunders to discuss these and other actions with our panelists. Thank you.
Thanks, Rachel. And to dive into these issues a bit more, I've got a distinguished group of panelists. Due to time, I'm going to give very short introductions, but suffice it to say, each of the three have very long and distinguished careers. They include Mina Shashamani from MedStar Health, who will be sharing some perspectives around where the provider community may be thinking. Patrick Conway, CEO of Care Solutions at Optum, who is approaching this as more of a payer hat, but also has other perspectives to share as well. And Sandra Wilkness from Families USA, who can share a lot around the patient and consumer voice, but also has other perspectives, especially around states, that she may be able to bring to bear. So Mina, I want to start with you. We've had a number of conversations about the good work that you've been doing at MedStar, thinking about how to pivot during COVID, given the value-based payment flexibilities that you have already. Want to sort of turn over to you to get your reflections on, what's worked well so far, and what really do we need to think about in terms of payment and delivery reforms to build back better after COVID?
Sure. Well, thank you for having me. It's great to be here. So, in terms of the work that we have done at MedStar Health around COVID-19, really it's been about addressing that continuum of care, where the only way that you can really address a public health crisis is by looking at the entire population and community and what they need. And so being able to link care in the community through prevention of both COVID, supporting social needs, supporting with patient education, and also supporting patients with chronic conditions who may otherwise end up coming into the hospital at a time when we really don't want them to come in. How can we further preventive care to hospital throughput, and how do we prepare patients for then when they leave the hospital, and how do we partner with our skilled nursing facilities, for example, both to prevent outbreaks and to encourage smooth discharge planning, as well as discharges to the community and back to a primary care provider, for instance. And I think since we last spoke, certainly this is part of continuous learning in terms of COVID-19. Just one example is, after our surge in our area, which was in April and May, fast forward a month or two, and we discover that there are patients who have longer term complications from COVID-19. And so since the time that we last spoke, we have set up a COVID recovery program so that you can support patients, again, through more of a multidisciplinary approach, where either the patient or their primary care doctor is not stuck thinking, okay, like, who do I talk to and where do I need to go? Instead, having, an intake clinic with a navigator who's supporting the patient, both for their, clinical medical needs and also their social needs. Because again, as we know, COVID-19 is very much related to health-related social needs and health disparities, and also being able to leverage the health system in a more organized way. So having identified specialists in cardiology, pulmonary, et cetera, who want to specialize in COVID care, so they get a critical mass of COVID patients so that they can better learn and understand and contribute to the literature on what these longer term complications are. So that's one example of where through the course of the pandemic, we have continued to learn and identify where there are some next steps. And another example I'll give is where learnings from our experience with the pandemic is helping us with non-COVID patients. So we set up, within 2 weeks, we set up a 10 hospital, care transitions program for all of our patients that really leveraged pharmacy, community health workers, you name it, rehab, primary care, to be able to provide that multidisciplinary full support. And certainly now being able to look at the data and where we're able to make the most impact, we're similarly identifying our non-COVID patients who can better benefit from these kinds of services. And so being able to expand in a thoughtful way, into those arenas. And I think both of these examples ultimately tie back to what this panel is about in terms of how do you continue to encourage that kind of continuous learning, right? Because you could say, okay, we're in the middle of this pandemic and the hospitals are worried about getting overwhelmed with COVID patients. It creates this perfect incentive to really focus on, avoiding unnecessary utilization in the hospital, really promoting community-based care. But that shouldn't be just during a pandemic. That should be part of how everybody is thinking about care. And so being able to continue to, I think a point that Rachel made, looking at where these payment models have provided those incentivizations at the outset to encourage investment, but where we can continue to utilize the data from what has happened to see where you can get the value to further iterate on those. And that will apply not just in a COVID scenario, but also in a non-COVID scenario.
Thanks, Mina. And Patrick, I want to turn this over to you for your perspectives. I know you've been doing a lot of thinking and work around a variety of ways and innovations to improve care. One question I really want to make sure we hit on is, how do we help independent primary care through these types of payment models? Because as we've seen this pandemic, independent primary care has been hit especially hard. So welcome your thoughts writ large about what have we learned and where can we go, but especially with that independent primary care lens as well.
Yeah, I think on primary care and especially independent primary care, before the pandemic, I think a lot of efforts on how we support that care model in my different hats, public payer, private payer, et cetera. And I think even more so during and post-pandemic. So to give some tangible examples, I wrote about this with a colleague of mine. If you think about the CMS Innovation Center programs, how does Comprehensive Primary Care Plus and next generation population-based payment models really incentivize and pay a population per member per month type model adjusted for quality and total cost of care that supports resiliency, independent primary care, a different payment model. And so I think did a lot of things at CMS when I was there. I think hopefully you'll see more in the future from CMS writ large and from CMMI. Blue Cross North Carolina, we made some pretty major investments, both directly and through partners like Aledade in supporting independent primary care. And there's even reference in the previous talk about some of the work through this period. And once again, the idea is, how do you move to a population-based payment model that isn't dependent on fee-for-service and volume and supports investments in a broader care delivery model, whether it's telehealth or virtual care or longer visits, home visits, mental and behavioral care, all the things you need to do to care for a population. Interesting. One thing we haven't talked about, my current role at United on the Optum side, where we have about 70,000 physicians and clinicians now. So we're one of the largest care delivery systems, if not the largest in the US. With our practices, we saw those that had moved to more fully capitated payment models did significantly better than those that were more fee-for-service. And we have a goal to move all of our practices to more of a value-based capitated type payment model over time. But they're just a different place along the trajectory. The other thing that our team did is we reached out to independent primary care practices via United and Optum and said, how do we support you through this? It was actually an incredibly positive reaction, whether it was through financial arrangements, through support on data analytics and all the different ways we try to support primary care. The reaction from independent primary care across the US was quite positive because it was such a strained time. And so how do you make investments in primary care to support them, whether that's capital and financing or the data analytic tools or other mechanisms to support that practice model, which is in our interest. And I think most importantly in the interest of a better health system for all.
Absolutely. Thanks, Patrick. And Sandra, I want to turn to you, especially given the good work Families has done on thinking about how to improve care for consumers, but also thinking about how to improve value writ large. Reactions that you have on this question about how to improve primary care and how those payment models can help there, as well as what lessons have we learned during the pandemic about how to improve care for patients and consumers?
Yeah, thanks, Rob, and I appreciate being here. And I just want to underscore probably the note that Patrick just ended on, and Mina referenced and Rachel did as well. And that's really the move towards more of a population health approach and really seeing the primary care provider and infrastructure as the bedrock of that, and really ensuring that that infrastructure is solid and in place. I think others have already alluded to the challenges for primary care practices. There's an estimate that nearly 40% as a direct result of reduced volume during the pandemic may not come back online as we try to build back, as you've noted, which is a pretty significant number. And what I just want to underscore is we hear repeatedly a resounding message, and this is from people across walks of life and political affiliations, that what's of central importance to them is a family doctor for every family. And I think that's a really critical message, because the implication is not just the clinical care primary care provider may be able to offer, but really it's the place to go to understand and to digest your holistic care and support needs, and really use that as that pivotal moment to address all primary care and social support needs. So we have also observed that those providers who are operating under alternative payment arrangements or have some sort of funding flowing in up front have been more resilient, have been able to offer those kinds of services and make meaningful linkages with other providers that we know are so critical to offer those supports. And beyond that, build the workforce that we really need to bolster that infrastructure that is the glue around those care coordination and linkage efforts to ensure that those supports are in place. So the only other thing I want to add, and because of others have covered this, is we similarly found that those providers who have integrated behavioral health and oral health services as well, who are really trying to do that whole person care, have fared better and are much more resilient in this current environment. So it really seems like a model we want to continue to support and scale and spread.
Thanks, Sandra. Another major theme that we wanted to explore in this panel is the fact that COVID has really uncovered and put a spotlight on existing disparities across the healthcare system. Those inequities, disparities were there in the before times, but they've definitely been thrown into sharp relief and in many cases exacerbated during the pandemic. And some providers, especially those that have more flexibility, have tried to address those types of disparities by increasing their services for social drivers of health or through other very targeted initiatives to try to improve care for all of their patients. And I want to turn to you first, Mina, to get your perspective on, what are you seeing out there that's working well? I know you've mentioned several initiatives that you've undertaken, say using community health workers and other novel approaches. But what do you see is working well, and what needs to be spread further?
Yeah, well, I think you teed it off with discussion of community health workers. I think one of the things that we know is that people respond better, and also you're able to, address issues more effectively when it's people from the same communities. And so where there are opportunities to create training programs and hire from the very communities that in this case are being hit hardest by COVID, you're able to create jobs and also address a real need. I will say that at MedStar Health, we're part of a grant in Baltimore, the Baltimore Jobs Program, where we trained community health workers from the most disadvantaged zip codes in our hospital catchment areas, and trained peer recovery coaches and community health workers with an eye towards how you move the needle on health outcomes, and also avoid unnecessary utilization. And being able to leverage those very same people for the pandemic has been key. So I think continuing to encourage efforts in that regard, where you can really both address the economic crisis and the health crisis at the same time, now during the pandemic and moving into the future. I think that's really important. The other thing that I would say is that the issue of social needs and community health really should not just reside in the provider realm, particularly when you look at like a small practice. They don't necessarily have the bandwidth or the expertise to be able to hire a community health worker and know exactly how to leverage them best. And I think there are opportunities for partnerships with community-based organizations who maybe have community health workers that they employ, train up, that they can partner with providers, for example. I think we need to think about this in a broader partnership framework than just, everything being on the provider. And then the last thing that I'll say is, as we move forward, things that we have learned even before the pandemic, we knew about, social health related social needs, about the needs of communities, about mistrust, things that have happened now during the pandemic. And now as we enter into vaccination, we need to leverage all of those learnings if we actually want to reach the communities that, need support with the pandemic and need to be vaccinated. We at MedStar, for example, we have a mobile health clinic in Baltimore that goes around. It's partnered with 8 community-based organizations to provide primary care out in communities that don't have access and, quite frankly, may not trust going into a doctor's office, right? I mean, Baltimore City is, where Henrietta Lacks was. And so, there's a lot that we need to continue to think through as we are now thinking about COVID-19 vaccination. Like, we offer flu vaccines, in this mobile health clinic, and being able to really have good community engagement for the vaccine will also be important as we continue to address the pandemic and as we think about things beyond the pandemic, because these are issues that will continue even when the pandemic is behind us.
That's right. And Sandra, I want to turn to you to get your thinking. Many Medicaid programs have really been out in front. Our home state of North Carolina has been doing some innovative work with Healthy Opportunities pilots that are seeking to try to partner community-based organizations with healthcare delivery systems, just like Mina mentioned. Wanted to get your thoughts on, what's worked well on social determinants of health activities by state Medicaid programs, and what could we be doing more to help support that?
Yeah, Rob, thank you. I think that's right. I think a lot of this has, Medicaid has really taken the lead, and a lot of this has been through demonstration authority and opportunity to experiment through that. North Carolina, of course, an obvious, great, and important example. Other good examples, the whole person care pilots in California are worth watching and understanding how they're trying to weave together health interventions and those really important determinants of health interventions that you're referring to earlier: housing, employment, food security, domestic violence, addressing all of those issues and doing it in a really coordinated and sophisticated manner. I think other, even smaller interventions, like in Arizona, there are targeted investments to address justice-involved populations who are also Medicaid enrollees, and really being thoughtful about creating opportunities for reduced contact with the justice system, and also savings in terms of the justice system and the healthcare system, and really allowing these people to live lives of dignity in the community. So I think those are some really important examples. I think, of course, there are larger efforts in Washington State and Oregon that are really, regionalized and systemic as well. And worth watching and building upon. And I think from a consumer perspective, this is really the drive to a population health approach, bringing in one of the most important players in the arena. I think the only other thing to flag is, states are really in a major budget crisis. The National State Budget Officers Association recently said it looks like states are considering up to 15 to 20% cuts across agencies. We know that Medicaid is usually one of those entities that gets cuts. And so the only other thing to flag here is not to cut those kinds of experiments, not to cut these evidence-based interventions that we know work to help improve people's health. In a haircut kind of approach. Let's really be thoughtful about doing it in an evidence-based manner. And then that includes stop paying for what doesn't work as a way to recoup those costs.
That's helpful, Sandra. And I think, there are definitely some hard times ahead, but hopefully we've learned some strategies that can be effective as states are having to make those types of trade-offs. Patrick, I'm going to let you have the last word as from your time at the perch at CMMI, how does what we've learned so far in terms of what we've learned about value-based payment during the pandemic and some of these care delivery reform successes affect the agenda of the incoming CMS administrator and the incoming CMMI director? Is it, should we continue what we've been doing? Are there things that we should be doing differently?
Yeah, so I think a few things. I think one, the good news is I think CMMI and value-based payment has proven itself to truly be bipartisan across Republican and Democratic administrations. So we passed the 10-year anniversary of CMMI, which, from the beginning stages, is good. How much progress we've made, for lack of a better description. And then I described in phases. You had a startup phase from Rick Gilflin to me, working with teams of people, including Mina, on sort of how do you launch these models? Are people going to participate? Moving from 0% of payments to over 30% in alternative payment models. So over $200 billion, over 200,000 signed provider agreements, which was really positive. And quite honestly, in the beginning part, you didn't know if that was going to happen. Then you have a next phase that, how do you move to more risk? How do you sort of move the next progression? How do you rationalize the models? I think we're sort of in that now. For the next administration, what I would encourage is a few things. One is, how do you make more of these models permanent? So there's been 2 that met threshold, diabetes prevention and Pioneer ACO, both of which are more than 4 years ago. So how do you make more? How do you certify them? How do you make them permanent? How do you become part of the payment program? 2, I think, is how do you have more sort of large scale, including mandatory models? So mandatory bundles were started, as an example, in the Obama administration. There was a period of who knows what's going to happen. And the Trump administration says they back them, but we haven't seen more yet. And so how does the next administration, for example, whether it's mandatory bundles or other mandatory models, test in a larger frame so it becomes a permanent, once again, the goal? Then you could imagine sort of a DRG inpatient system, you get to a whole DRG for 30 or 60 days of payment, which would transform our system. And then I think you have some open areas, drugs and other areas where we haven't figured out exactly how we're going to approach. So hopefully a new administration. And then, the last thing I mentioned is I hope, just because there's a geographic model as an example right now that literally started in the end of the Obama administration, took a long time to get out, and finally got out in the end of the Trump administration. You can always update these things, but I hope somebody looks at that model and says, how do I either implement this as is or make changes to it, but let's not throw it away just because, it came out in a different administration. Shouldn't matter if it's the right basic sort of value-based concepts. So those are some of the areas I would call out. And all this also points back to resiliency and investing in the system. So we incentivize total cost of care, quality and experience, the classic triple or quadruple aim, if you want to include provider experience and communities as well. So really appreciate the comments today. I think we hit on a lot of ground. And thank you for your time.
Absolutely. Thanks, Patrick. And thanks, Mina and Sandra and Rachel as well. I think, as Patrick noted, we've been able to really dive into what we've learned about payment and delivery reforms and over this pandemic, and especially thinking about how do we not only finish the pandemic strong, but also build back a better delivery system for the future. So with that, I want to turn back to our director, Mark McClellan, for a few closing remarks.
Rob, thank you very much, and thank all of our panelists today. We really appreciate as well all of you who joined us this afternoon at this very critical time in responding to the COVID-19 pandemic, with on the one hand, highest case rates and heaviest burden on our healthcare system that we've seen. On the other hand, between vaccinations, increasing testing capacity, and many innovations in healthcare delivery, the opportunity for coming out of the pandemic, not only at an accelerated pace, but also with a better healthcare system, better public health, and more equity for the future. We still have a long way to go, but I want you all to know that if you want to continue to hear about our Duke Margolis events and activities, please visit our website and sign up for our newsletter. We'll get you on our mailing list. You'll be able to hear about future events and activities building on what we've talked about today. I do want to give a special thanks to our experts at Duke Margolis who participated with our panelists in putting together this event. You saw many of them. I'd like to call out a few people who've been operating behind the scenes to help put this together, including Mark Jappinga, Katie Green, Luke DeRocher, and Patty Green, as well as others at Duke-Margolis. And we look forward to seeing you again at future events. And for now, wish you a safe and happy holiday season. Thank you.